Hi, everyone. I have the pleasure of introducing Ali O'Day. He is a human biology major at Stanford and really enjoys swimming and the beach.
All right. Hi, everyone. So yeah, my name is Ali, and this summer I had the privilege of working with Dr. Robert Hagar at the UCSF Benioff Children's Hospital. He works in the pediatric oncology and hematology division. And this summer we focused on the effects of hyperuricemia on kidney function in patients with sickle cell disease at Benioff Children's Hospital. So for a brief introduction, sickle cell disease is a recessive heritable blood disease that affects roughly 300,000 newborns worldwide every year. And this disease causes polymerization of deoxygenated hemoglobin, resulting in abnormally rigid red blood cells, as shown here on the diagram to the right. And affected individuals experience something known as vaso-occlusion-induced tissue hypoxia, which leads to pain crises. And so while recent advancements in medical care have greatly extended the lifespan of sickle cell disease patients, chronic kidney disease is still the leading cause of death and morbidity for adult sickle cell patients. So logically, that's the area we decided to focus on this summer. So for our objectives and methods, our primary aim of this investigation was to examine the effects of elevated serum uric acid, also known as hyperuricemia, on chronic kidney disease in patients with sickle cell disease. And renal function was measured by changes in something known as their longitudinal glomerular filtration rate, or their EGFR. And we hypothesized that sickle cell disease patients with hyperuricemia will experience worse chronic kidney disease. And so our method involves working very closely with the electronic medical records, the EMR, from UCSF's Benioff Children's Hospital. So we collected patient data from clinical care over the past 2 years, and patient demographics, things like age, sickle cell type, zip code, laboratory markers for sickle cell disease, renal function, those were all abstracted, and renal function over the last 2 years was assessed. And we used clinical and laboratory values to investigate the effects of long-term renal function. And our results were as follows. So our primary finding, which allowed us to reject our null hypothesis, is illustrated here nicely in this box plot. The main finding was that there was a lower mean EGFR recorded for patients in the high uric acid category. And so what that means is patients, of the 155 patients that we looked at, 44 of them that qualified in the high uric acid category had lower mean EGFRs, meaning they had lower kidney function, which worked out with what we hypothesized would happen. And then an additional finding was, as demonstrated here in this scatter plot, was a negative linear trend that we observed between mean EGFR and uric acid levels. And then if we were to look at the table, figure 3, the table on the top, we see that even when we control for sickle cell disease type, because there are multiple types, and gender, we see that the -7 value highlighted here was our key finding from the summer. There was still a 7-unit drop in EGFR for every 1 unit increase in uric acid, which is very significant. And so for our conclusions and next steps, as we hypothesized, sickle cell patients with hyperuricemia experience more rapid worsening of chronic kidney disease. And this was shown by our key finding from the whole summer, our key finding of the 7-unit decline of EGFR for every 1 unit rise in uric acid by linear regression, even when gender and sickle cell type were controlled for. And interestingly, we found that the survival analysis showed a smaller percentage decline in renal function in the hyperuricemia cohort, and some explanations might be that whether the study cohort is representative of the general sickle cell population, or whether hyperuricemia cohort has already had prior renal decline, making any future changes less noticeable. It's also important to acknowledge that this investigation had a relatively small sample size of only 155 participants, so that does limit the generalizability of the findings from this summer's research project. And then for next steps, further studies should look at how other collected variables, such as BMI, zip code, race, and ethnicity, also affect, modulate the effects of uric acid. And also, so this investigation demonstrated a statistically significant negative relationship between uric acid and renal function. But fortunately, there are widely used safe drugs capable of reducing uric acid levels. And one such drug is liraglutide, which is an angiotensin receptor blocker, certain type of drug, and one such angiotensin receptor blocker is highlighted here on the screen. So following confirmational findings with hopefully larger sample sizes and more robust studies, so confirmational studies, angiotensin receptor blocker prescriptions may become a new standard of care for sickle cell patients with hyperuricemia. Thank you very much.
Nicely done, Ali. Very interesting. All right, so who's got the first question for Ali? All right, I'll start us off then. Maybe you could start by explaining what is uric acid and why would patients necessarily have higher levels of uric acid than another patient? Like what are sort of predictors of that in the patients?
So in terms of predicting where the uric acid is coming from,
Yeah.
it's like my understanding from working with Dr. Hagar is that it's from following the breakdown of certain red blood cells. It's like a byproduct of that. And given that the turnover, because of sickle cell patients having kind of all those other issues they have being faster, they tend to accumulate uric acid faster. And then another important thing we really need to look at is, do patients with kidney failure have higher uric acid, or is higher uric acid causing kidney failure? So that's going to take like some more time and kind of looking at when each of these things are like what follows what in terms of the timeline. But it's a kind of a byproduct of the breakdown of those red blood cells.
Excellent. All right. Was it Eric's got the next question? Yeah.
Oh, I actually thought Zane was
Zane
ahead
did-
of
yeah,
me.
but I didn't. I don't see Zane. So.
Ollie just answered my question while
Oh,
answering.
okay. Got it. Awesome.
Great presentation. I really liked it. And my question was, earlier you mentioned how you guys also collected zip code information. And I was just curious if you did anything with that information in your study.
So we didn't have time to work with that, but that was like one of the aspects I was most like interested in for this summer's research project. So I definitely like to keep working with him to work on it. And basically what we were doing was like tracking that zip code to like the mean household income in their area to try to see like how other socioeconomic factors are also influencing like CKD and chronic kidney disease and sickle cell anemia in general.
Looks like maybe that answered CM's question. Denise, you got another one?
Yeah, I don't know. Hopefully this is just a quick one for you, Ali. And you may have already mentioned it, but has like chronic kidney disease always been the leading cause of death for folks with sickle cell disease? Or is this like a newer, I don't know, thing that we're seeing?
So the history of sickle cell disease is definitely something we read up a lot about in the beginning. And it used to be like sickle cell patients, I believe like 40 or 50 years ago, wouldn't make it past like their teenage years or sometimes even younger. And now we have a lot of sickle cell patients from the ones I would go and like shadow and like see some of the patients in their like 30s, 40s, and sometimes 50s. So there used to be like other more pressing things that would kind of lead to morbidity and other things earlier. Those are kind of with the advancements of medical care kind of gotten taken care of. And then now we're where we are at now, it's kind of, so it hasn't always been this way. No, it's only kind of more recently, I believe over the last like decade, that chronic kidney disease is kind of the more, because it like they accumulate that the organs accumulate damage because of the like how aggressive sickle cell moving through your bloodstream is. So kidneys kind of just accumulate that faster than all the other things, but it was not always this way. No.
Excellent. We've got one more minute here. Anybody got another question for Lily? And I'll ask if you, in your multivariate analysis, did you also look at age as a predictor or dietary calcium or other things that are related to at least kidney stones, not necessarily kidney failure, but but in sickle cell patients, was that at all related to some of the outcomes?
So that's kind of what made it difficult, because everybody's renal function is declining. So like when we looked at like, yeah, even it's like so that was kind of hard. Right. And then when we did control for age, we kind of saw no changes. Yeah. And so we kind of, that is something we looked at, but then ended up not controlling. And the statistics on that were getting a bit complicated. So I'm not 100% sure about how it worked, but everybody's kind of renal function was declining over time. So it was hard to control for age.
Understood. Yep. Good point. All right. Well done.